At some point, you might need to be hospitalized for one reason or another. And as we've learned, about 1 in 3 patients over age 65 will leave the hospital more disabled than when they arrived. What about those older patients who do well during and after a hospital stay? What steps can you take to leave the hospital in better shape and not be readmitted later? I'll discuss those topics with our special guest today. Joining me is Dr. Kathy Maxwell, Assistant Professor, Vanderbilt School of Nursing. Dr. Maxwell has done extensive research about how our bodies age and how that can impact hospital outcomes. Dr. James Jackson is a neuropsychologist at Vanderbilt University School of Medicine. Dr. Jackson is Assistant Director of the ICU Recovery Center at Vanderbilt and studies delirium in hospital patients during and after hospitalization. And Gretchen Funk, Associate Executive Director of 50 Forward Supportive Care Services. Gretchen's team helps patients and families to prepare for what happens after a hospital stay and provides support services. Thank you all for joining us today. Dr. Maxwell, I want to ask you about the issue of age versus physiology. A lot of times you hear people say age is just a number. And it seems like, based on your research, that that is true. That is not the most important determining factor to how a person does in the hospital. Is that correct?
Yeah, so that's right. So I got interested in studying these patients from my background in critical care and trauma and in observing older adults after they were injured. And so we've done a study where we followed almost 200 hospitalized older adults after they were injured, and we followed them for 1 year. And basically we determined that it's their frailty status or their functional status or where they are from a biological aging perspective that is driving what their outcomes are going to be after injury.
And one of the most noteworthy things I read in your research was the comparison between 2 patients that were like 30 years apart. Tell us a little bit about that, because I was fascinated by that.
Yeah, so one of the things I really remember from back when I was a bedside nurse is having 2 patients that are the same age, 78, 79 years old, both hospitalized for injury. One recovering and doing very well, went back to their baseline, back home, but another who declined and unfortunately passed away within a year after their injury. And I was fascinated with that, you know, why same age, what's the difference? And we've really come to understand that it really is their baseline, where they are in terms of biological aging.
And specifically, you use the term frailty.
Yes.
Okay, and that refers to?
So frailty is not a particularly appealing word, but it's the best word that we have to really describe someone's body and its ability to generate energy to recover and sustain itself.
So how frail a person is before they go
Yes.
into the hospital can have this impact on the outcome.
Yes.
Okay, we're going to talk some more about that in a minute, but I want to bring Dr. Jackson in. And Dr. Jackson, your work has to do with delirium and patients who've been in the ICU. And I think it would be helpful for you to explain what delirium is, because I don't know that I had a clear understanding. I mean, is it a coma? Is it a brain injury? What is delirium in the hospital?
Glad you asked that. We get emails almost every day from people around the country at our ICU delirium research group asking that very question. I think for a long time people thought it was simply confusion. Delirium equals confusion. We know now it's much more than that. Delirium is really a potentially serious neurologic syndrome, and it's characterized by a couple of things. It's characterized by a really striking change in attention. Patients typically become inattentive. They have a change in their level of consciousness, and it's something that happens very quickly. In some cases, delirium is what we call hypoactive. That is, patients are a little confused, but quietly so. In some cases, it's hyperactive. They're pulling out lines, trying to climb out of bed. The hyperactive delirium is usually recognized. Unfortunately, the quiet delirium is often missed in a clinical setting. No one intervenes on it, and that's concerning.
So it could be that grandma's just laying there looking somewhat content, but could be in a state of delirium.
We think that happens in probably 50% of cases or so in the ICU, that there are patients who are indeed delirious, but they're not pulling on lines, they're not climbing out of the bed, they are quiet. If you engage them, you'll often find out that they don't know what day it is, they may not know where they're at necessarily, they may have real rapid fluctuations in consciousness, but unless someone asks that, they often won't know. And if these patients don't present management challenges, too often, even in 2018, they're not assessed for delirium.
Okay. And related to our topic of older adults who are patients in the hospital may not be in ICU, and yet we've learned that delirium is common in that age group. Is it the same kind of phenomena with those older patients that aren't in ICU but experience delirium?
We think it's really problematic wherever it shows up, whether it's in the general hospital ward, whether it's in the nursing home, wherever it might show up. We worry that it is really like a canary in a coal mine. It's a harbinger of bad outcomes to follow, which is why we think we need to attend to it.
Okay. And do you know what causes it in those other situations, or even in ICU?
There really are a lot of causes. Some of them are metabolic in nature. Some of them are related to changes in environment that are very foreign and frightening to patients. Some of them have to do, probably the biggest reasons have to do with drugs and sedatives, the administration of drugs and sedatives that could be what are called deliriogenic in nature. That is, they induce delirium in people, which is why increasingly the state-of-the-art approach in the ICU or outside the ICU is to decrease sedation, to really sedate patients as little as possible, because in so doing, we think that we will probably prevent the development of a lot of delirium.
Okay. I want to talk to you some more in a moment about your research, but Gretchen, one of the things that I know from talking to Dr. Jackson is delirium can show up even after a patient leaves the hospital, which is an indicator of something I want you to address, which is what happens after patients leave the hospitals, because many times problems can come up and they're readmitted. So leaving the hospital is not the end of the road, is it?
Right, definitely. And 54, we work with families every day that are planning for hospital admissions or are facing admissions that were unplanned due to a fall, some kind of trauma. So we try to work with families to talk about what could happen, to talk with them about needing to be empowered to speak with the doctors, ask many questions. I think a lot of times with older adults and families, people aren't sure what to ask or feel that they should respect the medical profession and everything will be taken care of, but there are really so many pieces to put together, from ensuring that a person can come home safely to an environment that is now appropriate based on their post-hospitalization, to make sure their medications are in place, to not assume that mom or dad will be back to the functional level that we expected. So really to have families be prepared for what could happen, and you can't really know until after a hospitalization. Each person is different.
And some of that decline may come afterwards because they don't have those support services, or is it sometimes related to the hospital stay? And
sometimes it's related to the hospital stay, related to their past diagnoses. We work with folks that have mental health histories, that those conditions can be exacerbated by a stay in a hospital. There can be disruptions of their medication regimen while they're in the hospital, so getting them back to a baseline with those are important. Some people go to a rehab stay, then you have a whole nother foreign environment for somebody to adjust to. So we work, along all those steps, and I really think it's wonderful that the medical professionals are looking at these things that are common. We see with each individual family how things are so different in that constellation of a family and how they can support each other.
And the goal is to prevent readmission, which I think a lot of people may not understand is quite common.
Very common.
Tell us a little bit about that.
Well, I think that Medicare, is looking really closely at that to try to help everyone understand that there are many pieces that you have to put together to prevent that readmission, and that hospitals have their place in the acute care setting, but if everything is not set up post-discharge, that person will end up back in the hospital. And it can be for something very different, you know, dehydration, medication interaction problems. So we really do try to put everything together for the families to give them the power to make a successful discharge plan. But families are very challenged also. You know, you have older adults who their children have their own children and their own working lives, and I think people try to be optimistic, and what we say is we should be optimistic for the eventual outcome, but really rally around that moment in time that's so crucial.
And in the documentary, we learned with one of the patients, discharge actually started before, but planning, I should say, discharge planning started before she ever went in the hospital.
Right, and that's what we try to do with families, to try to say, okay, your mom has been fine on her own, alone at home. Before this hospitalization, you cannot rely on that at all. So really to have somebody there, because the falls post-discharge, even falls unrelated to the reason for the hospitalization, are very common, and then you end up with this snowball effect that's very difficult to come back from. So we really try to help families to get those resources in place. And it can't always be the family member, and we recognize that. So we try to see what else is out there to support them.
Okay. Dr. Maxwell, I think that might be a good time to talk about your research, because you found a lot of decline after these patients left the hospital. And some of it was related to frailty and some of it wasn't. But tell us a little bit about what happened to these patients after they left the hospital.
Okay, well, let me start by telling you, so we determined what these patients' baseline frailty status was. Were they frail, were they pre-frail, or were they non-frail, or what we call robust? And then we followed them for 1 year after they were discharged from the hospital. We called them at 4 time points to find out how they were doing. And we looked at their mortality, we looked at their functional decline, and we looked at their readmissions to acute care. And we found that even when you factor in the severity of their injuries, their comorbidities, that it's that baseline frailty status that's driving how they're going to do. So what we saw...
Which is, again, for people watching, that's the frailty condition before they ever entered the hospital is more relevant than the severity of why they might have been in the hospital.
Yeah, and most of the injuries that they had were not particularly severe injuries. 67% of them were injured in a fall, and so their injuries were, you know, maybe a fractured arm or a fractured hip or fractured leg, or maybe not even those fractures, maybe just 1 or 2 rib fractures, or so the injuries themselves were not that severe. But what we saw was that in the non-frail group, of course, they had some functional impairments afterwards, but they slowly returned to their baseline, and the majority of them came back to their baseline. In the pre-frail, they also got worse. They had a slower recovery. They improved, and the majority did not quite make it back to their baseline. But in the frail group, they declined, and they stayed at that level of decline out to, this is among the survivors, out to that same level of functional decline at 1 year.
And you mentioned survivors because we have a graphic that actually, in the graphic, we see that quite a few of those who were frail before hospitalization do not survive long term.
Yes, yes. In the frail group, at the end of 1 year, 4 out of 10 had died. 4 out of 10 had declined functionally from where they were at their baseline, and only 2 out of 10 actually made it back to where they were before they were actually injured.
And in the non-frail group, it's only 0.5 out of 10, so that is a big difference.
Yeah, and 6.5 out of 10 made it back to their baseline.
Okay.
Yeah.
Were you surprised by those findings?
Yes and no. So it's consistent with what I had been seeing in my clinical work, and so it just kind of bore that out. So, but then, you know, when I actually saw it from a research perspective and from a statistical analysis, it's like, wow, it really does bring it home. And when you look at those graphics, you see that.
I think it's pretty amazing that
Yeah.
it is those patients' condition before they went in and how frail they were.
Yeah.
So that says a lot about what patients as consumers can do
Yeah.
should they face a hospitalization. And we'll talk about that in a minute. But
Okay.
delirium also continues, you have found, after patients leave the hospital in some cases, correct?
Indeed, it does. It often persists.
Okay. Tell us about that. How is it permanent? I mean, how long does it tend to last? What are you finding?
Yes. Let me make a couple of distinctions. So in some cases, delirium continues, no disputing it. In other cases, patients are cognitively impaired with delirium, but the delirium drops off, falls away, and then these patients continue to persist in having really meaningful cognitive impairment. Problems with their memory, problems with attention, problems with a domain we call executive functioning, which is really, really disruptive. It has to do with balancing a checkbook, driving, multitasking. Often our delirious patients are the ones who are particularly likely to develop this panoply of badness, if you will, of cognitive problems. And we're really concerned about that because frequently the clinical picture is one of a patient who was very high functioning before they went to the ICU, fully independent, managing well. They leave the ICU. At a year, the literature would say 1 in 2 of those patients is no longer in the workforce. Many of them have dropped out of school. Many of them are underemployed. If they are still employed, many of them are not driving. So we worry a lot about delirium being a driver of functional debility in many of the patients who survive the ICU. Long after the delirium passes away, the impairment stays.
And is it also true that the impairment may not really even show up until long after the delirium? I mean, they may be home and trying to function before they really see the damage. Is that correct?
It's totally the case. Often what we see in our patients is that in the early days after they leave the ICU, they don't do very much. They're rehabbing at home, if you will. So they haven't tried to drive, they haven't tried to balance a checkbook, they haven't transitioned into the leadership roles that they were operating in. So often they're a little diluted. They think they're fine. Now, as the tasks increase in terms of challenge, they quickly realize they're not fine. They quickly realize they're impaired. And in some cases, they realize it too late. That is, they've returned to work now, and now they're fired. They've returned to school. Now they drop out because they really don't have the capacities they had before, but they just lack an awareness about how severe their deficits are.
So tell us about your work in helping these patients navigate the impact of this afterwards through the support group and the recovery program.
So we have a couple of approaches that we use. We have a program called the Vanderbilt ICU Recovery Center. It's a specialty clinic, much like they have specialty clinics for cancer survivors, for instance. It's a multidisciplinary specialty clinic where patients come in early after leaving the ICU, and one of the main things we do is we educate these patients about the severity of their deficits, and we try to refer them to specialty services where they can get the help they need. We refer them to a speech pathologist to get cognitive rehabilitation. We refer them to a physical therapist to get all of the maximum benefit they might get from exercise. We also have a support group. And this is really, really helpful because often these survivors of delirium of the ICU, they have these many problems, but they think they're quite alone. So in the support group we lead, there are probably 20 of them around the country now that have blossomed. In the one we lead at Vanderbilt, these patients newly out of the ICU really link arms with people who have been long out of the ICU, and they help each other, and it really is a lovely thing.
And I wonder if patients seek this on their own, or is it sort of, are they automatically referred to the support recovery?
Increasingly, we're trying to refer them.
Because you anticipate there's going to be some impact
We
from
do.
this ICU stay.
We do, and hospitals around the country increasingly are having candid conversations with patients before they leave the ICU, basically to say, you may develop PTSD, you may develop cognitive impairment, you may develop depression. Here's what it looks like. If you have these symptoms, don't wait, seek help.
And that applies to people of any age.
Really does.
Okay. So some symptoms, if I'm a caregiver of someone who has experienced ICU stay in the hospital, get home, what am I looking for that might indicate needing some help?
First off, I would say if you're a caregiver, don't talk yourself out of the fact that there's a problem that you're seeing. I think people too often do that. If you're seeing a really meaningful change from baseline, if you notice, for example, that your loved one is having problems finding words, if they're having problems navigating in familiar places, if they're not recognizing people, if they're having a difficult time transitioning back to the complicated tasks they could do before, that's a problem. If they're mechanical and now they're trying to watch Monday Night Football and they don't know how to work the Apple remote, that's a red flag. Those are the sorts of things that we look for.
And Gretchen, do you help folks navigate what to do? Because even if you're the caregiver or the patient, you recognize this, sometimes you aren't taken seriously, or you think, oh, I don't want to go back to the hospital. They're just going to think, you know, I'm overreacting.
Right.
So what do you help folks do in those situations where they notice something still isn't right?
Right. And we do try to look at the frailty issues, you know, trying to be very realistic about what is the baseline at which this person is entering that situation, and then to be looking for changes, as Dr. Jackson is saying too, that we want people to be optimistic, because we do feel like that has an effect on outcomes also, but also to be realistic. So we see many folks that they come into the hospital living independently. Maybe they live in an assisted living after that. There are some indicators that mean that you will not return to your baseline. But what we say to families is it's good to be sort of hyper-vigilant for that time after the hospitalization. People sort of peak around the hospitalization, and then they breathe a sigh of relief when that ends. But really, we know that for older adults especially, that is a really critical period to be sure transition happens well. So almost to overplan, we had a family we worked with recently that they knew they could take care of their mom's needs when she got home, they thought, and then she came home and she needed more physical care than she anticipated, and she did not want any of her family to provide that to her. So then we were left on a Sunday afternoon trying to figure out what kind of a company could come in and help, and we have those resources, so we connected that, but family was very surprised. They thought they'd had those conversations, but the older adult thinks, oh, I'll need this level of care. But really, if they need physical help with bathing and things, families are not always appropriate to do that. So it's sort of thinking a few steps down the line of what you might anticipate, and just having the conversations, because families sometimes are not comfortable with those conversations. So at 50 Forward, we can get involved as a sort of neutral third party to say, you know, we don't know your particular situation, but other families, you know, want to think about these things to be prepared.
And in helping people transition from hospital to wherever they go next, do you find that people have trouble with dealing with the providers? I mean, are the healthcare providers doing enough to help people make that transition successfully?
And I think everyone is well-intentioned, and we all sort of have our lane in the process, you know, the hospital, the acute care, the skilled nursing facilities. I think that the transition periods have been identified as real critical times. I picked up a gentleman discharged on a Friday afternoon from an acute care setting to go back to his assisted living. The assisted living had no way to get his medications. The hospital couldn't release him with the medications, and the assisted living, their process was not in place. You know, they have a company that sends the medications on sort of a set schedule. So he and I stopped at the CVS pharmacy with the paper scripts that the hospital did give us. So there are those pieces that, unless you know that, you know, I think many people assume, oh, of course the assisted living will have those medicines, but they don't understand those two systems. So I think everyone is trying their best. Everyone's very well-intentioned, and nobody can do it all, but those transition pieces are where things could fall down.
And it's a little bit siloed.
Oh,
It's not
yes,
that people
right.
aren't trying, but they're all in their lane.
Right, they're not connected, right.
Okay.
And I think the medical pieces are covered quite well, but then these social determinants around support are where it's very difficult. It's the who will actually drive this person from the hospital to the next setting. So those pieces, I think we still have more work to do as a society.
Well, and it's good to know there are resources,
right.
and we'll have some information about how
Thanks.
people can contact
Thanks.
you on our website.
Yes, thank you.
Kathy, before we wrap up, I know that you have spent a lot of time helping people to understand how to improve their baseline frailty, because we've talked about how it contributes. So tell us what you've done in that regard. So practical things that people can do to make that better, because it can be done, correct?
So we've realized that that people don't really understand this concept of frailty and what's going on, what's happening to their bodies. So really my work has become all about educating people and empowering older adults to make conscientious decisions to manage their own personal trajectory of aging. And I believe that if they can do that, it can improve quality of life, maybe decrease their healthcare utilization, and prepare them for that last phase of life that we're all eventually going to get to. And so I've been going out into the community, doing community presentations, and have developed a booklet here that talks about all of these things that we're talking about, that kind of explains in very layperson terms what's going on, and then looks at 8 specific areas that are very important for older adults to think about as they age. And those areas are safety, food and nutrition, physical activity, relationships and community, sleep and rest, healthcare decisions, finances and aging, and mind-body health.
And this is a free booklet that you have made available to people.
It is,
Okay.
yes.
Based on your work. And when do you start? I mean, you mentioned that this is not just for people in their 60s.
So we know that after age 30, our bodies begin to decline very, very, very slowly, 0.5 to 1% per year until the end of our lives. And so no matter where someone begins giving attention to healthy aging, they can elevate themselves up to a more steady state out closer to the end of their life, so that the window of time that they are frail or have loss of activities of daily living can be much smaller than someone who doesn't give attention to that.
Okay, that's good to know. Real quick, Dr. Jackson, this information that we're talking about today is important also because of cost efficiency. Can you just briefly talk about how dealing with this internally in the hospital can ultimately save money?
No doubt. I think earlier this issue of readmissions was referenced, and it's really important. It's a real dynamic, and certainly in our cohort studies, we've seen people who have been readmitted to the hospital sometimes 10, 15, even 20 times in a year, people who've had ER visits 50 times in a year.
So getting ahead of it and dealing with it as you do. In
Getting
your project.
getting ahead of the curve is really important, because often what happens is with each subsequent readmission, it's a little bit like you're drowning. You come to the surface and you get pushed down. Each time you come to the surface, you get pushed down a little bit further. Each time you get pushed down a little further, the complications are greater. You have fewer resources to throw at things. The more depleted your family is emotionally. Now you're not just taking time off from work, now you're on disability. So if there's a way to basically stop the cycle, there's no doubt that it will save massive money from a financial standpoint, but more importantly, you're saving emotional capital, I think.
Very good. Well, you all have given us some great information that I think as consumers of healthcare that we can use, and that's what's important. We all have a role, the medical community and consumers. Thank you for joining us, and thank you for watching. If you would like to learn more about Aging Matters, hospitals, and health risks, visit our website at wnpt.org/agingmatters.